background originally was in doing politics, philosophy and economics here at Oxford. And then I strayed into brain surgery in the way one does. In England, of course, medicine is an undergrad. You go straight from high school to medical school.
Right.
Unlike the States where you go to college first. So I'm slightly unusual among English doctors for having done a different degree before I did medicine. And then when I became a junior doctor, I more or less came across neurosurgery by chance and immediately fell in love with it and felt that was what I wanted to be.
Right. You write about this, and I thought I wanted to ask you about this. You make it sound as though you ended up in neurosurgery by happenstance or something like that.
Yes, in many ways it was. I mean, I found neuroscience the most interesting part of the preclinical medical studies. I didn't really see any neurosurgery as a medical student. I might have been influenced by the fact my infant son had a brain tumor at the age of 3 months, and we were lucky he survived and made a complete recovery. But it was more or less by chance, yes. It wasn't a plan.
Right. How did you transition out of philosophy into medicine?
Oh, long, complicated story.
Long, complicated story. Okay.
I wanted to do something practical. I like using my hands. And also my parents brought my family up with a strong feeling we're here to make the world a better place rather than just, in a nice way, rather than just entertain ourselves.
Right. You write about that at that time when you were deciding to go into clinical medicine, that maybe it wasn't such an altruistic motivation.
No, I don't think it was. I mean, all of us, the idea of pure altruism or pure selfishness, it's a two-sided coin. I mean, doctors have to be paid a salary, so it's a balance, as of all these things. Yes, I mean, I wouldn't have gone into medicine if there wasn't a sense of social service involved. But I think what particularly attracted me to neurosurgery was, one, the brain, and two, it's very dramatic and dangerous and exciting, or so it seemed at the time. My view of it now, looking back, is rather different.
Right. I find that rather interesting because I imagine to pursue a career in neurosurgery, you have to be very passionate, very ambitious. Yet you write that when you look back on your career, you don't miss it.
No, and I don't, which surprised me in some ways, because when I was in practice, all I wanted to do was operate, and the more difficult and more challenging and more dangerous the case, the more I wanted to do it. And I had to kind of learn to restrain myself. One of the most difficult things for surgeons to do is not to operate. You know, this old saying that to a man with a hammer, everything looks like a nail. And you learn through bitter experience that often it's better not to operate because there are so many, in effect, more or less hopeless cases in neurosurgery. But at the same time, if you decide not to operate, you always say, well, am I being a coward? You know, have I not got the bottle to do it? It's a difficult balance you have to struggle to find throughout your career.
As you've progressed from a younger doctor to now a more senior, you're since retired from your practice.
Yeah.
You do a lot of consulting and pro bono stuff.
Yes, and I was just doing a long opinion online for a difficult case in Nepal, in Kathmandu, just before you came.
Oh, did you?
Yeah.
Oh, very nice. So what is that line between, pushing yourself and looking after the patient's interests and taking on difficult cases and not being a coward but also being humble?
Well, it's a very difficult balance, and you learn from experience, and of course experience is all about making mistakes. And there's no easy solution to that problem. I went into neurosurgery a very committed egotist, I suppose, very ambitious. I left it convinced of the importance of team working and to get away from the model of the great individual surgeon. I think, as I learned fairly early on in my career, if I had a very difficult case to do, particularly the big tumours in the cerebellopontine angle I specialised in doing, it was much better if I did it with a colleague and we took it in turns. And it is happening more in medicine in this country now anyway, but it needs to happen more. It's the point is, human nature being what it is, other people are better at seeing my mistakes than I am. My sort of self-deceptive optimism bias means I tend not to see my mistakes until afterwards. My colleagues are more likely to see my mistakes than I am, just as I'm more likely to see theirs. But it's very difficult as a surgeon, particularly in something very dangerous like brain surgery, to admit to making mistakes, to admit to oneself, let alone to anybody else. It's very tempting to say, well, it's going to happen anyway, it's a hopeless case, natural history, etc., etc. There's so much morbidity and mortality in neurosurgery, it's very easy to become a bit complacent about bad results. But if you spend your whole time torturing yourself about bad results, you can't do the work. So again, it's a difficult balance. But I think having good colleagues who support you psychologically, but also with whom you can discuss difficult cases, is really, I think, central to the practice of good medicine.
I think what makes your storytelling so compelling is just how honest you are.
Yeah, dare I say it myself. I mean, there's nothing new about medical memoirs. They've tended to be divided into the books by young doctors. I mean, their great American example is the one called The House of God, by Samuel Shem, I think is the pseudonym, which was written 40 years ago, but still reads very well. There are many other English equivalents, where young doctors basically write a semi-satirical, slightly kiss-and-tell expose. And then there are books by older senior doctors, usually who have retired, which tend to be celebrations of success, and the bad aspects of the job tend to be rather hidden. And I think it's true to say my first book, Do No Harm, which was published now 8 years ago, was unusual because as a senior doctor, I was still fully in practice at the time. I talked about some of my successful results, but I talked a lot about failure and also about the psychological stress of the job. When the book was published, it's been a huge worldwide bestseller, much to my surprise. I think it's been translated into 37 languages,
wow.
which is very unusual. But when it was published, I've got a lot of I trained for various reasons, a lot of American residents who came to work in my department in London. So and I've been to America many, many times. Mm-hmm. So I know the system there fairly well, and the whole culture of the country, which I both love and hate. And I was very worried when my book was published there that my American colleagues and readers would say, God, it's third world neurosurgery in Britain, and this guy's mad, and totally incompetent. He makes all these terrible mistakes. But I got some wonderful emails and letters, mainly from senior American doctors and neurosurgeons, saying they thought the book was marvelous. And I was telling things as they really were. The interesting thing is most of the letters are from retired neurosurgeons.
Oh, yeah.
Because in some ways, it's only when you're retired you can kind of take the blinkers off and realize just how all your career has been walking along a really very narrow tightrope, trying to keep your balance between compassion and scientific detachment, and between being a team worker and being a keen individualist, between making money and medicine as a vocation. There are always difficult balances you have to try to find. And as of anybody in a tightrope, if you look down, you don't like it. You tend to lose your balance. So you look ahead and try to almost deny and hide from yourself the fact there are always difficult, really moral questions throughout your career. The actual technical operating, surprisingly, is quite easy by comparison. But I think any senior surgeon will tell you, actually, once you've learned how to operate, the real difficulty is in the decision-making.
Right. You talk about these dualities in your book. You mentioned that as a surgeon, you're so fascinated by the brain and how our consciousness can arise from...
That's in my third book, yes.
Exactly. But when you're operating, you have to push those thoughts to the back of your head because that's...
But they're never absent, just like the anxious family on the other side of the operating room door. You know they're there, but you just don't want to get emotionally involved with that. You just want to, and that's what makes operating so exciting and addictive. You live very intensely in the present when operating. Operating is never boring. Even a simple carpal tunnel operation. I'd like any operating. It's just so stimulating. You live so very intensely.
Have you found similar stimulation in your retirement?
No.
No?
There's nothing quite like it. But I don't particularly want to. I suppose bicycling very fast downhill is slightly exciting. No, but I don't miss it. I don't want to go back to it. That could be that's because I'm older and my appetite for risk and danger is reduced. I'm also on androgen deprivation therapy for advanced prostate cancer, which I thought must have a lot of psychological effects as well.
Right.
As all the physical effects of having no testosterone circulating. So that might influence me a bit as well. No, I in a funny sort of, I said you have to find a balance between compassion and detachment. And as all doctors, we end up right from the start of our careers. We divide the human race into us, which is the medical profession, and them, which is patients who fall ill. Most of us go through a stage as medical students when you learn about all these horrible illnesses. We start with very minor symptoms, a bit of blood on the toothbrush. I remember I saw a young girl when I was a medical student who had acute lymphoblastic leukemia, and it had presented with a bit of blood in her toothbrush. And then, of course, if you've had a bit of blood in your toothbrush yourself, you panic. It might be leukemia. And you learn you have to separate yourself from that. You have to have this mindset where illness happens to patients, not to doctors.
Right.
Because I neglected my symptoms of prostate cancer for far too long. If I'd actually gone to seek professional help earlier, I probably would have been cured. I probably now am incurable. I don't know how long I'll live. And part of that was our simple human cowardice, not wanting to face up to facts, just as so many people are doing about climate change. But part of it also was this medical thing of illness happens to patients, not to doctors. And it was very reluctant to cross the threshold as a doctor to become a patient. And this is one of the things I discuss in my third book, this strange business of being a doctor and then becoming a patient. It didn't teach me anything I didn't know already about how miserable it is to be a patient, humiliating, demeaning. I knew all that, partly because my wife was an anthropologist with Crohn's disease and has often been in hospital and has told me a lot about, as a trained observer, as an anthropologist, what hospitals are like from the users, from the patient's point of view. But what did surprise me when I was first diagnosed was how frightened I was, how upset I was. I might have thought, having been dealing with death and disaster for 40 years as a doctor in a very frontline specialty, I might have thought I'd have been a bit more calmer and more mature about it. I wasn't. I was absolutely terrified. That was before I had a very, very high PSA, which usually means you've got established metastatic disease and the end is probably nigh. But there's a few weeks when I didn't know. All I knew was I had a very high PSA, 130. Only 5% of men have a PSA as high as that. And I was scared witless. It was pathetic. I was very surprised by that. I thought I'd have been a bit more grown up. But the other thing that surprised me was I felt very strongly, well, actually, I've had a very good life. I really can't complain. And I thought about all my own patients over the years, because I specialized eventually, mainly in brain tumors. And many of them were malignant, and most of my patients were younger than I am now. I'm now almost 73. And I felt very, very strongly, alongside this sort of panic, you've had a very good life. You had a very interesting life. I've done well. I'm not proud of everything I've done by any means, but there are many things I sort of regret. But I know that I've had a remarkable life. And I thought, well, I've been very lucky, So I can't and shouldn't complain. So I try not to complain, though I still dislike having cancer, and I intensely dislike the hormone therapy.
Right. I want your final book is about that entire narrative that you just sort of summarized in like a two minutes there. I want to start from the beginning of that story with you, if that's okay.
Mm-hmm.
So in your book, before you talk about being diagnosed or getting treatment or anything like that, you talk about getting a brain scan.
Yes, that's right. It was a sort of joke. One of my colleagues wanted some age-matched controls. This was 2 or 3 years ago. So I had an MRI brain scan, and this is before I had cancer. And I spent my whole life looking at brain scans.
Right.
And I knew that a few people in their 70s or 80s, their brains look relatively young. Most of us, as we get older, our brains shrink. And some of us do get quite a lot of white matter damage, so-called white matter hyperintensities. Now, I thought I was pretty smart and clever and everything else. And I was still very fit then. I'm less fit now because of the hormone therapy. So I had the brain scan. My only concern was, will I be able to lie for an hour without moving? In fact, it was easy. And then eventually, obviously, sort of unconsciously, I was a bit worried about what the scan might show. I was thinking more about maybe an unruptured aneurysm or a silent brain tumor. But what it showed was really what looked to me like very marked age-related changes. My brain was really quite atrophic, and there was a lot of white matter damage, these high intensities.
To your surprise, or
to my surprise?
Okay.
Yeah, to my horror. I mean, in retrospect, well, it's an old man's brain scan, and I'm an old man. And the fact of the matter is, until I went on treatment for cancer, I was pretty well. I could write and think and talk, and run. So in a sense, I shouldn't have been surprised. So it was a sort of wake-up call. I was getting older, and the book starts with discussing that. And then the pandemic came along, and then the cancer arrived. So the book was going to be a book really about neuroscience, starting with my own brain scan. But then it got hijacked by events, firstly by the pandemic, and then by cancer. So everything changed, and the book changed as well.
Sure. I think it's a testament to life, right? Life taking its course. The environment, the entire world endured a pandemic, which changed things for a lot of people.
Yes, it did. I was already retired by then. Yes, it changed an awful lot. What I find distressing is that one might have thought the pandemic was a wake-up call to how vulnerable civilization is. And the evidence about climate change seems to me completely incontrovertible. And there's just simply not enough being done. Too little, too late. I find all the models and statistics completely terrifying. Not for me, I won't live that much longer. But I've got three granddaughters. They will live to see, possibly quite apocalyptic changes.
Right. And in discussing the pandemic, you yourself being of older age during the onset of the pandemic, you don't really describe being as concerned for yourself.
No, I was to begin with, when we knew very little about the disease. And also, I volunteered to go back to work in the hospital service.
What was the motivation there to go back to work?
I ought to, I did, but then I started to think, more and more stories about medical staff, hospital staff dying from COVID. And I got rather frightened. But then I remembered, but I thought, in fact, they didn't need me. There's, what's the use of an elderly brain surgeon? I wouldn't be much use proning patients. I have too much backache. But then I remember just before the pandemic started, before the lockdown, I'd flown back from Ukraine, and I was ill in a very odd way, with very, very severe abdominal pain and a nosebleed, first one for many years. And then I came across a paper about atypical presentations of COVID, and abdominal pain is one. It may not have been COVID, but I chose to believe maybe I already have it, maybe I'm already immune. It might have been wishful thinking, but then I no longer worried. And I felt quite calm and fatalistic. I was more worried about my wife with a Crohn's disease. She's on immunosuppressants, and she got COVID. They're not what we could do. It clearly was COVID, and she was actually quite ill. So that was more worrying. No, I had an easy pandemic, so to speak, compared to many people.
Well, I think it was difficult in other ways because during this time you were diagnosed with advanced cancer.
Well, yes, and halfway through I was diagnosed with cancer, which kind of changed things a bit. Yes.
Right. I think that poses an interesting dilemma for you in that you've completed this illustrious career in neurosurgery, and you mentioned now that you're removed from it, you can look back on it.
Yes.
Without maybe the rose-colored glasses.
Well, I mean, I must have treated and seen tens of thousands of patients over the years. And ultimately, I have very little idea about how I came across. It's one of the difficulties about being a doctor, which many people don't realize, doctors themselves. Everything in life, we get better at doing it by repeating it, rehearsing it, by criticizing it. You know, you're recording this. You can look at it afterwards and decide whether next time you could do better.
Right.
But as a doctor, when you're talking to patients, you don't. You can't repeat it. And the patients will never ring you up next day. I'm talking about communication. They'll never ring you up next day and say you were terrible, you were very good. So it's really, although medical students nowadays get a certain amount of teaching about communication, it's really very difficult to learn to do something well if you never get feedback, and you don't. And you learn really often from your own bitter personal experience. And as so much healthcare is handed out by doctors and nurses and paramedics, we're all fit, young, healthy people, I kind of cringe when I think of some of the things I said or must have said when I was a young doctor. I hope I got a bit better as I got older. But again, you're in a position of such power over patients that it's easy to get a bit corrupted and a bit complacent. I suspect most doctors would be rather surprised if their patients honestly told them what they thought. Or some of them. I mean, some patients are going to get on well, and others you don't. But after my own experiences, I having been so frightened myself to begin with, I must have terrified so many patients. I couldn't help it. I said, you got a brain tumour. But of course, certainly in the English culture, and probably in America as well to a certain extent, as patients, we don't want to burst into tears and scream and shout. We repress it all and take it away down the corridor. So my own illness confirmed to me what I knew in principle already, but there's no substitute for personal experience, how doctors have such a narrow view of what their patients are going through. And this is necessary to some extent. You know, as I say, when you're operating, you don't want to get all anxious and involved, worrying about the family outside. But it's a question of balance, and it's very easy to become a bit too pleased with yourself.
Does having that clinical background and having treated so many patients, then becoming a patient yourself, did that understanding make the diagnosis easier? No,
it didn't. On the other hand, I think I was very polite. I was very polite and undemanding as a patient. It's always difficult as a doctor to be a patient. I probably was too polite and undemanding. And I was so frightened and confused. I was just like any other patient. I couldn't really take in what I was being told. I didn't ask enough questions. It was a very odd experience. I've now read up a lot about prostate cancer, and I know a bit more about what's going on. But I was surprised at just how tongue-tied and awkward I was when I became a patient. What parts of the patient experience do doctors not understand or neglect in their service to patients, now having been one yourself on the other side? Not giving patients enough time and space to ask questions, which is both one about sitting there, not appearing to be in a hurry, trying to encourage them. But, patients take time to... I knew this in principle. I did pediatric work as well as adult. And I'd have to tell parents, your child's got a brain tumour. And so news like that is so devastating. You can't really have a very practical conversation afterwards. You haven't really have a second conversation. You need, with very serious problems, ideally you need a series of conversations, which of course, on the basis of outpatients in a busy NHS clinic in this country is almost impossible to achieve. Listening, to try to summarize that, I'm a very bad listener. Doctors need to be better at listening to patients, taking time. I hope my patients felt I treated them with respect. I thought I was trying to treat them on the whole as equals. But whether I succeeded or not, I don't know. And I might be deluding myself.
So how has being a patient affected the way that you look back on your career? Because of course it's a remarkable life that you've lived. And but you talk about looking back at your experiences as a young doctor.
I think as a young doctor, I cringe a bit, but then as a young doctor, you need to inflate your self-confidence to do the work, because really you're not as good as your patients want you to be. So you have to deceive yourself and think you're better than you really are to do the work, because you have to project a confident, competent, knowledgeable image when you talk to patients. So I was sort of aware. Now, I wasn't really quite aware of that at the time, how much of an act is involved when you're a young doctor. When you're much more senior and experienced, it's easier to be honest and to be yourself, because you know what you're talking about. But a lot of the time, young doctors don't know what they're talking about. And they have to pretend to themselves as well as to their patients. Because the best way of deceiving other people is to deceive yourself. Look at politicians. People who believe their own lies are very successful in life, but they're very difficult to cope with.
So apart from the doctor-patient interaction, I presume you spent much time in the hospital being treated for your advanced cancer?
No, it was all outpatient. That's apart from the biopsy, it was all outpatient.
Oh, okay. Well, I wanted to ask you about that experience, how healthcare settings, how they're designed and how your experience was.
Well, the hospital I was treated in is a specialist cancer hospital, and actually the treatment I received was very good, particularly the surgical. I was very impressed. It was very slick, the whole setup. And I didn't think they particularly knew I was a surgeon myself. So that was fine. Outpatients is always a humiliating, tedious business by the very nature of it. You're sitting there with lots of other old men with prostate cancer.
Right. You described the patient experience. You referred to your wife earlier in the conversation, and then now having been a patient yourself, you use the word humiliating.
Yeah, it is. It's very.
So for someone who's never been a long-term patient, can you describe what you mean by that?
Well, your small things are done to your intimate parts of your body. You have to do what you're told. You're totally in the hands of complete strangers, and it's humiliating. You're no longer master of your own fate, your own situation.
How did that register with your ego?
I knew it would be like that, and I accepted it. I didn't like it, but I accepted it. And I did not want to be a sort of self-important retired doctor.
Well, I think the way you write is a testament to that. There's this line in your book that I think is so funny. You were quoting one of the nurses who I don't know exactly what procedure they were trying to do with for you, but she said that you had too much matter.
Oh yes, when I found the radiation matter. Yes, well that was a little pun on the subtitle of the book.
Yes.
Because I tried to describe in fairly graphic detail the sort of fairly slightly indelicate aspects of what I went through. And in kind of as a counterpoint to all the stuff about the brain and consciousness and the meaning of life. It's a matter of life and death.
Right. And now that your hands are, no longer doing brain surgery, you can think about these things more philosophically.
Yes. Yeah, I think so, yeah.
And when you look back on your career, Do you glean any insights about the human condition and consciousness in ways that maybe you didn't have time to while you were, in practice?
No, not really. Partly because I went into medicine late, older than most people when they become doctors in this country. So I've always felt a bit of an outsider. I've always had a slightly sideways look at the work, which is why I think I could write the books I wrote. No, I don't think I learned anything drastically new, other than no. But there were three things. Firstly, how upset I was and frightened when the diagnosis was first made, even though I'd spent all my life dealing with cancer and death. Secondly, but I felt so strongly I'd had a fantastic life. I don't want to die yet, but I really can't complain. And thirdly, I didn't miss what mattered to me most of all for most of my life, which was looking after patients and operating. So I was rather glad to get away from it. Because it's so stressful.
Right. That's baffling to me as someone like new in their career to think that by the end of it might not matter as much as I. Well,
it mattered at the time, and I had a very fortunate career, and also working in the National Health Service in this country. I worked in it during some very good years when it worked very well, on the whole, and I had a lot of autonomy. And there's been a huge change in the last 10 to 15 years. The NHS, rather like the Canadian healthcare system, is struggling a bit, I think.
Right, it is.
There are all sorts of reasons for that. So I was very lucky to work in the NHS.
Would you do it again if you could go back?
Very difficult to answer that. I'm often asked that. Because so many things have changed. I mean, neurosurgery has changed. As I say in my first book, I fell in love with neurosurgery because of aneurysm surgery, which is like I say joking, it's like bomb disposal work for cowards, because it's not your life at risk. And it's a very exquisite, delicate, I like fiddling, and I loved working down operating microscopes. It's a very intense world. It's wonderful. Modern operating microscopes are just bliss. But all that's changed, because now most aneurysms are treated radiologically with intra-arterial catheters, which is wonderful for patients. Not good for neurosurgeons, but wonderful for patients. It's a much, much better way of treating aneurysms. So that's changed. And also there are more neurosurgeons. It's all become more specialized. When I became a consultant neurosurgeon, I did everything. I did spinal stabilization, aneurysms, tumors, you name it. And now it's all much narrower. So I guess people are becoming better at doing specialist problems. But there was always a certain attraction to be able to do everything. And I was very busy. I had a huge practice and was operating, say, 20 years ago. I was operating 4 days a week. By the time I retired 7 years ago from full-time work, at the age of 65, I retired because I got totally fed up with the loss of autonomy, but also as only operating 1.5 to 2 days a week. I was getting a bit bored. I wanted to operate, and I felt there wasn't enough work for me to do.
You mentioned in your retirement that the memory of many of your past patients sort of not haunted you, but
they're there all the time. They keep on cropping up. Yeah,
reflected on that a lot.
Yeah, almost every day, another patient, the memory of a patient I had forgotten for 20 or 30 years.
Is that traumatizing or consoling?
No, it's not consoling. I mean, many surgeons would tell you they don't remember the good results. We tend to, because the good results is, well, you've done the job. That's what's expected. The bad results are the ones you remember. I don't know whether other surgeons are quite so troubled about it. I'm not troubled all the time, but it's kind of always there in the background. And that's the nature of the work. I don't think I was a worse neurosurgeon than others. I don't think I had more. I hope I didn't have more complications than other surgeons. I did do a huge amount of operating, so I would have had more complications simply
Naturally.
as a percentage. But given surgeons on the whole don't like talking about their bad results, you don't know. I don't sort of think, I wish I'd done something different. I don't beat myself up. I accept I made mistakes. I accept there were a lot of bad results given the nature of neurosurgery without my having actually made a mistake as such. It's rather that you have to bear witness to so much suffering and sometimes be a bit responsible for it and kind of be detached from it. And I think you pay a price for that in some ways. You end up almost a bit damaged. And one of the nice things about being retired is I feel a more complete person again. I'm no longer dividing humanity into us and them, and that is quite nice. I now have a less complicated response to I hear or see human suffering.
I find that very, very interesting. You said you used the word damaged. I think a lot of people outside of neurosurgery and medicine would look at like a brain surgeon and think that you have to be a callous individual to succeed in that domain.
I don't know about callous, but you have to switch off a large part of the empathic bits of your brain to do the work, because you will see a lot of terrible things.
So while you
and you just mustn't get too involved. So you do suffer a bit in that sense.
While you were doing the work and you were very involved in your career, I imagine much of your fulfillment in life was coming from operating and taking on serious cases and pushing yourself as a surgeon. So now that you've left all of that behind, where do you find that same sense of joy? What brings you that
My granddaughters, my grandchildren.
Your grandchildren.
And I got a workshop, I make furniture and garden. I've been spending a year making a very elaborate doll's house for my third granddaughter. I've made another elaborate doll's house for the first two granddaughters. So I love making things all the time. I'm always busy. And I was writing a lot. I still write. I mean, my books are really just extended versions of the daily diary I've kept ever since I was 12 years old.
I wanted to ask you, what inspired you to put pen to paper and just write?
Well, I write anyway for myself, always have done. And it was my wife, in fact, my second wife, who have been together now for 23 years, Kate, who's an anthropologist and a very successful writer. She's a brilliant writer, and she came up with all the titles of my books and the documentaries about me.
Lovely.
And when we first got together 22 years ago, she'd say, "What were you doing at work?" And I'd sort of put up my laptop and read what I'd written. And she said, that ought to be a book. So she sent me off to see her literary agent. And he said, "Yes, you can write, but, the problem people like you have is sort of structuring it." So I spent sort of 10 years kind of rearranging and fumbling. And suddenly one day it seemed it all just fell into place. Though I had a wonderful editor who's edited all three of my books, and she has made a huge contribution. That's not saying other people are better at saying my mistakes than I am.
Right.
It's the same with writing. No book is so good that it won't be improved by some external commentary from an agent. Everything I write, I show to Kate. My first book was sort of that thick, the first draft. Kate went through it, was that thick. My agent went through it, was that thick. My editor went through it, was that thick. And it got better every time.
Your own personal journal that your books have sort of emerged out of. What do you hope for those? Do you hope to pass it down?
It's a huge problem. I discuss it in the book.
Yeah.
Basically, I feel I should destroy it. Not that it's anything very personal or embarrassing, but it's a nuisance. And I don't want my children to have to decide what to do with it. As well as it's an endless old hard disks, books. It's a mess. And I rarely look at it myself. But I also know that to actually destroy it I find terribly difficult. It would feel like a sort of suicide. So I'll probably just dither and leave it too late, and it'll be somewhere in an attic, and my poor children will have to decide what to do with it.
Fair. You talk about retirement, and naturally when people retire in their and they're older in age, the existential questions start to creep up and things like that. And your situation is a little bit more unique because you've been diagnosed with advanced cancer, which kind of exacerbates, I guess, a lot.
Yeah, but we're all getting something like this sooner or later, unless we're really unlucky and get dementia. No, as I said, that I feel terribly strongly. I've had a very fortunate life to be born in the middle of the last century to parents I had here in Oxford. I had a fantastic education. I've had a very interesting life. I've travelled all over the world. I've worked in many different countries. I'm, in that sense, I'm ready to die. I don't want to die, but I've got no, as I say in my new book, I've got no bucket lists whatsoever. There's nothing I need to do or want to do other than finish the Doll's House, which I probably will do by the end of the year, and hopefully I'll live beyond that. Hopefully I probably will. But other than that, and I want to live longer, obviously we all do, and I want to live longer for my wife's sake and my family's sake. But I've really been terribly lucky. I really have no right to complain at all. If you say, well, the fact of the matter is, the greatest happiness in life, in my opinion, is making other people happy, or is helping other people in one way or another. One's own happiness, in inverted commas, holidays, good meals, they're all very transient, You can't take them to the grave with you. I like that phrase, no pockets in the shroud. And although I don't want to strike a corny anti-capitalist, anti-materialist note, there's no question of the fact that thinking there's happiness, more happiness comes in more money, more consumption, more material goods, it simply isn't true. And there's lots of evidence that beyond an income of about, $60,000 a year,
right?
Social factors are much more important about determining the quality of your life, your family, your work, the feeling you matter and your life means something. And on the whole, there'd be a few abstract mathematicians and physicists who live in a sort of different world. On the whole, the meaning of our life is a social thing. And as a doctor, you have this great privilege. You just by doing your work, you're helping people, hopefully.
Right. I imagine through your work, it's not hard to find or see that meaning.
Yeah, exactly. You don't when you go home at night. You don't have to worry. Have I been good today? Well, the challenge is to do really well. The challenge is to put. So if you ask me what I'm proudest of in my career, although I've worked for 30 years in Ukraine, I've worked in many countries, and hopefully some of my colleagues there think I've been helpful. But the most useful thing, I think, I pioneered various ways of operating, but the most useful thing was I was able to create, outside the 2 neurosurgical floors in American parlance, in my hospital in London, there's some big balconies, which were there sort of by mistake. There was a design error, or at least they made the building smaller than the original footprint. And after years of campaigning and raising charitable money, I was able to turn these balconies into a really nice garden so that neurosurgical patients can get directly out of their bed into the outside world, be surrounded by trees and green plants with a nice view over the slate roofs of South London. And I know that's given so much relief and happiness, more happiness within limits, to so many patients. And I'm afraid I don't think anybody else would have done it, probably. There are other balconies in the hospital, and nobody else has done it. And that I'm very proud of. And it's also because I've always loved trees and plants and the environment and things like that.
So when you say more useful, like more useful beyond even the utility of yourself as a neurosurgeon?
Yes, because everything there somebody else could have done. That's the point. I didn't do anything. Sure, my work in Ukraine has been somewhat unusual. But again, it was only doing what somebody else would have happened more or less in time anyway. So it's nice to feel one's done something a bit more unique. And I suppose also my books fall into the same category.
Right.
I'm told, I'd like to think it's true, that many doctors and patients have found particularly my first book very helpful. Certainly many doctors have approached me and said it was very I've often think I had some bad results and I felt terrible about it, and I was very reassured to hear that you write openly about this aspect of the work. I'm not saying doctors should order psychotherapy and counselling and be weeping on each other's shoulders, but I think the nature of the work is such, it is often very sad and very painful, and you shouldn't feel ashamed about that.
Right.
And it's the price you have to pay. And what's really special about being a doctor, depending a bit on the specialty you're in, is failure. Because we all fail to a great, because patients die. And if you do dangerous surgery operations, there's no such thing as a safe operation. And what really, the real challenge of being a good doctor is coping with failure, whether it's a mistake or not, learning from it, sharing it with colleagues, using it to do better in future. That's the real challenge, and not being broken by it.
How did you remain intact while you were, enduring some of those failures as a young doctor?
Wearing blinkers, basically. Just not thinking too much, denying when I could have done things differently. But having said that, when I became a consultant, a senior doctor, my first few bad results were absolutely devastating. And I felt quite ill for weeks. I felt I've got to go on, so I carried on. As the years went by, the bad results were fewer on the whole.
Right.
Because I was getting more experienced. Above all, I was learning when not to operate. And to recognise a difficult case when there was one. And I still felt, when there was a bad result, I still felt terrible. But usually only for a few days rather than for weeks. Because I'd say, well, come on, Marsh, you're still alive and well. We've been through this before. It's not the end of the world. The patient may have died or been left terribly disabled, but so it goes. But then you mustn't become complacent, and you must always think, well, what will I do differently next time? And what can I do to tell my trainees and my colleagues about this problem? Now, that's supposed to happen at morbidity and mortality meetings, but in my experience, both in the States and in this country, tends not to happen. Problems tend to get brushed under the carpet.
On the contrary to failures, I think most people would look at the life of a surgeon as heroic. Is that how you?
No, I don't think so. Well, the only heroic aspect to it is dealing with failure. If every operation was successful, there'd be nothing very special about it. The triumphs are only triumphant because we have failures. And the challenge is dealing with failure. That's the heroic aspect.
Well, you mentioned...
No, the heroic thing, patients want to think doctors are heroes.
Right.
Because we want to think doctors are gods who never make mistakes.
Exactly.
I'm trusting my life to this man or this woman, therefore they've got to be superhuman heroes. That's all crap. That's a psychological necessity. It's intolerable as a patient to think your doctor he or she doesn't know what they're doing. And we tend to wear blinkers. If you start doubting doctors, it's very, very difficult.
Well, you mentioned your work in Ukraine and your initial motivation of like high altruism to go and serve.
Yes, it was basically. Yes.
But now that you look back, your sentiment is changed a little bit.
Well, I think I got a lot of things wrong. I misunderstood the colleague I worked with, though he misunderstood me. I'm still very close to the country. I was there a few weeks ago. I'm going back there in a few weeks' time. Things are complicated. That's all I've learned. Things are complicated. You shouldn't stop trying to change things, but I suppose you need a certain naive enthusiasm to start doing it in the first place.
Right.
So I don't regret much of what I've done. And I think a lot of it was a bit vainglorious, but it was with a good end in sight. I never had any interest in making money, rather the reverse. Some of the work I did overseas, I lost money to some extent. No, I think looking back, you realise how complicated life is and how much our lives depend on random chance.
Fair. I want to pivot the conversation a little bit to the idea of suffering. Because you spell out this idea that we're so concerned with extending our life and prolonging it, but that comes with certain pitfalls that maybe make life not as meaningful or enjoyable.
Yeah, no, it's a big problem, particularly in the States, of over-treatment and not knowing when to stop. It's certainly, as I discussed in my first book, to tell a patient, go away and die, or worse to that effect, is really hard. And the temptation is to operate again, or if you're an oncologist, another round of chemotherapy. So this is very difficult. It's difficult for both patient and doctor. All I'd say is, I think, without people being very honest, without doctors being very honest about what's on offer. And we know in countries like America, where medicine is largely, but not entirely, commercial, and hospitals have a vested interest in doing more brain scans and more operations and more chemotherapy, this, that, and the other. It leads to huge expense and probably a lot of unnecessary treatment.
There seems to be, so in your retirement, naturally people look back on their lives and they, they reflect and all of those things. But as you move up in age, you write about this fear about the quality of your life diminishing, and this real fear you have of
dementia.
Of dementia specifically.
Yeah, absolutely. Well, I mean, as we get older, dementia is a very real possibility by the age of 80.
Right.
It's about a 40% probability, I think. Like that.
And you describe almost desperately not wanting to live that way.
Yes, exactly.
I'd
rather die from cancer, because I don't know. Maybe if I'm cured of the cancer, which is unlikely but possible, maybe I won't get dementia. We all have to die from something sooner or later. And what really matters is we should live our lives now so that when we're lying on our deathbeds, if we're compos mentis, we can look back on our lives and feel we did the right thing for other people, for the world. That's what matters.
Has your diagnosis changed the time horizon of, let's say, your goals or plans?
No, not really, because I didn't have any long-term plans because I was retired.
Fair.
No, it adds slight pressure, but I'm assuming I'll be alive for another year or two minimum. The only problem is whether I'm on prolonged hormone therapy or chemotherapy, and even now after 2 years of hormone therapy, the muscle weakness and fatigue is extremely irritating.
Say you had been diagnosed midway through your life.
Be very different then, very different, because my children wouldn't be adults. Cancer at my age is part of growing old. Cancer is essentially an old person's disease, although all the cancer charities show pictures of poor young women with no hair and kids. They're very much the statistical minority. It's essentially a disease of old age. It's something you have to accept. And how much treatment you go through, well, you don't know until it happens to you. And that's why I have one chapter in my new book all about assisted dying, because I think assisted dying is, I think bicycles and the availability of assisted dying are the two hallmarks of a civilized country.
Bicycles.
Yeah.
That's an interesting analogy. I want to conclude our conversation with this. So your books have helped a number of people.
I hope so.
Clinicians and patients alike, and the general public has benefited from this work. And they're largely memoirs about your experiences.
Yes. Yeah.
But your own mother's left a memoir.
Yes.
And I wanted to ask you how that's touched you, being a writer and a clinician, and her
Well, she wrote her book sometime before she died at the age of 82 from breast cancer. But my brother and elder sister edited it, and we had it printed privately. And she did give me an early version to read, and I read it, but without really paying it close attention. And in the last chapter of my new book, I discussed this. And like many of us, I think, as we start reaching the end of our own life, we think more and more about our parents and all the things we'd like to say to them. Because I had loving parents, I had very wonderful parents. And I kind of took them for granted. In a sense, perhaps that's what they wanted. I want my children to take me for granted. I don't want them to have any sense of, or minimum sense of obligation towards me. I don't want to be a burden. But No, my mother was a very unusual person, and she was a German political refugee from Nazi Germany. And there's many conversations I'd like to have with her now. Of course, she's not there. And I say in the last chapter, I say we're like little boats which our parents push us out onto the ocean. And we sail full circle around the world. But by the time we come back to the harbour from which we started, our parents are long gone. So that's kind of sad, but so be it.
I think there's a certain beauty in that metaphor. So I'll let you conclude with this. So you've written 3 memoirs now.
Yes.
And in our conversation, you discussed that this is very likely the last.
It's the last book for adults.
So,
I'm starting to work on a children's book because during lockdown, I spent 2 years telling FaceTime fairy stories of my own invention to my 2 older granddaughters. After 2 years, my imagination started to get a bit creaky. But they're quite funny stories. And I would illustrate them myself and then send them postcards with pictures. So I'm starting to work on that. That's when I've finished the Dulsac set. It's the next project. I've always got something to do.
Oh, that's lovely.
So I'm not going to write another book for adults. No. But and the idea of the book for the kids, it will actually be for my granddaughters. And whether it then gets published or not is a separate issue.
I see. Well, what would you like your readers to leave with from your public works? What would you like that sort of legacy or message to be from you?
The failure in life is very important, and one must not let it defeat one. One should be honest, and when one's failed, be realistic about why one has failed, but not let it put you off trying harder, maybe doing things differently. So, life is hard. Life is hard. And I'm afraid anything worth doing is hard work on the whole. My children criticize me for that. They say, you always gave us to understand if it doesn't hurt, it's not worth doing, which, you don't want to make a cult of it. But no, particularly in medicine, the challenge is dealing with failure, learning from it, and doing better next time, not being broken by it.
I think it's a perfect place to end the conversation. Thank you very much for coming on the show.
All right.